what I consider to be a pandemic seesaw. There have been new variants that have alpha strain. There's, of course, Delta and Omicron and such like that. As a result, many of these new variants were no longer effectively treated with some of the monoclonal antibody treatments that had been developed months earlier to the original strains as well. And so the FDA rescinded authorization for many of those things that you guys may remember as the Regeneron cocktail and things like that. There were new antibody therapies that then came around that looked to be very, very promising for the new variants like Delta and even the original version of Omicron as well. And we'll talk about what happened to those new therapies. And there have been new antiviral agents that have come around in just the last few weeks and months as well that look very, very promising too. So it's been a seesaw of ups and downs. Unfortunately, some of our monoclonal antibody therapies that appeared to be good for Omicron now are not good for the latest subvariant of Omicron, BA2, and we'll talk about that as well. So it is an up and down, and there's a lot of information going back and forth that can leave our heads spinning sometimes. And so I really want to spend the next 40 minutes or so, and then I'll take questions afterwards, talking about what I think are the most important things to know for those of us out there with arthritis and related autoimmune diseases, and how we can go about living with what is now becoming an endemic of infection and not just a pandemic as well. So there's been remarkable progress, like I said, in understanding and preventing infection and treating infection with this novel pathogen and the disease it causes. And so it kind of raises the question, how have we come to get to where we are so quickly? And it's really through several unique scientific innovations. One is collaboration. Well, that's not so unique, but it is actually unique. Scientists have traditionally worked in their own little rabbit holes in their own little labs and have been rewarded for individual production and productivity without collaborating with other people. That is a model that has changed in recent years, such that now scientists are rewarded for collaborating with one another. And that has resulted in the springing up of international registries and data collection shared by all in an open source format that has allowed the rapid accumulation of knowledge. In addition, there's also been a rapid communication of clinical experience, literally from the bedside back to the bench. People have been very, very observant about how COVID has been behaving, especially in the early phases and as the variants sort of come along. And that information has been transmitted very, very rapidly back and basically around the world. There's also been an explosion in translational science, which has seen a convergence of virology, immunology, and molecular biology come together to basically take new scientific methods and apply them to this new pathogen and the pandemic. But in spite of all this, to sort of paraphrase Winston Churchill's famous saying, as sort of World War II was dragging on, we're really still at the proverbial end of the beginning. As I said a moment ago, this pandemic, while it looks like things are beginning to open up now, the BA2 subvariant is around, and it's around in a fairly prevalent manner. And it really is indicative that we may be very well living with this pathogen for a significant period of time to come. And that's why I think this is a very timely moment to give this particular talk. So there are special considerations we should all think about, that I think about certainly as a doctor, but when I care for patients who are immunosuppressed, but certainly for those of you out there who are yourselves immunocompromised, to think about during the pandemic. The first is, how do you define immunocompromised? Such a simple question like that. Well, there are general causes of immunocompromised states. Patients who have diabetes, for example, and malignancies, particularly patients who have blood malignancies like leukemias and lymphomas with impaired bone marrow and lymphoid tissue function, are considered to be immunocompromised. There are people who have genetic causes who are born with immunodeficiencies as well. And I put in here common variable immunodeficiencies, which is acquired, which is either can be seen earlier in life or can be acquired throughout life, is a relatively common cause of immunodeficiency. But I think what's relevant to most people on this talk, and it's certainly overshadows all of these, are the number of patients who are immunosuppressed by virtue of the medications they take, whether those be immunosuppressive medicines for their autoimmune disease, or whether they be chemotherapy type like medicines for cancers and other types of malignancies. But, so patients who take immunosuppressive medicines for transplants, for autoimmune diseases, or who take chemotherapy are themselves immunocompromised, not just because of their underlying disease, but also because of the therapy that they're taking as well. And that's really what I want to focus on today in my talk to those of you out there. Many of you who I'm sure fall into that category. Now, I give this, when I give this talk to other people, I try to make the point that this is not a niche talk. I'm not just talking about a tiny little percentage of the population. The number of immunocompromised patients in the United States is not trivial. There are over 700,000 patients who are the recipients of solid organ transplants over the last 30 years. There are more than 1.5 million patients in the United States right now who are currently living with leukemias or lymphomas. And of course, the prevalence of autoimmune diseases and arthritic diseases is mammoth. In terms of autoimmunity, between 14 and 23 million people, according to US Census figures, have an autoimmune disease of one type or another, which is about 5 to maybe 8% of the US population. So we're not talking small numbers here. And many of you out there who sometimes feel like you're out there on a limb all by yourselves really aren't. There are a lot of you out there. Now, not every patient with an autoimmune disease is heavily immunocompromised by virtue of taking an immunosuppressant medication. There are many patients, for example, who have Hashimoto's thyroid disease or something, who take a little bit of thyroid, synthroid replacement and are not necessarily immunocompromised. But there are a sizable number of immunocompromised patients for whom we really do, as doctors, need to provide care in the era of COVID-19. And you guys out there need to speak up. If you feel as though the world is ignoring you by removing mask mandates in airports and on airplanes and other large settings, again, the number of patients who are immunocompromised in the US is in the tens of millions. And you're not a very, very small lobby, definitely by any means. Now, what we have learned about the clinical course of COVID in immunocompromised patients has evolved over the last couple of years as we've gotten more experience and learned more from our registries and studies. We've learned, for example, that immunosuppression may lengthen the duration of infection and the period of infectivity with which patients have COVID-19, such that the standard 5-day quarantine may not be relevant in patients who are immunocompromised. Furthermore, it's not surprising that COVID-19 outcomes may be worse in patients who are immunocompromised, and I'll show you some data about that. Certain immunosuppressive medicines are worse in the setting of COVID than other immunosuppressive medicines, meaning that certain classes of medicines are more associated with severe COVID-19 than others. And I think it's important to understand that although being immunocompromised in general is a bit of a handicap, there are worse ways to be immunocompromised than others, and we can talk about that too. We'll also talk about, I won't talk about controversial or rare cases where patients can develop flares of autoimmunity or new onset autoimmune diseases after having had COVID-19. I believe I've seen 1 or 2 cases like this over the last couple of years. I think that they're still relatively controversial and the mechanisms haven't really been sorted out particularly well, but certainly the specter of that is out there, although I don't really have time to talk about that today, and there aren't a lot of good data on this. And finally, we also know that vaccine responses to currently available COVID-19 vaccines are likely impaired in many immunocompromised patients, more so in some than in others. And again, this will relate to the type of immunosuppression a person is taking for their underlying disease. And we'll talk about that in a little bit as well. So just to give you a little flavor of what I mean by persistent, longer standing infections, this is an example of a single patient published in the New England Journal a couple years ago from Harvard, who had an autoimmune disease that was treated with multiple immunosuppressive therapies, both at the same time and sequentially. And what they were found in this patient, who appeared to be consistently coming down with COVID-like symptoms over and over again, is they were able to document waxing and waning viral infectivity and viral loads up to day 152, which is when the patient passed away. So for more than half a year, or roughly half a year. And when they did genomic analysis of these recurrent strains that appeared to be infecting this person, they genetically supported the evidence that this was the same virus that was just recrudescing over and over again and evolving as the ongoing infection was sort of recurring over time as well. And again, this is up to 5 months. So not just 5 days of quarantine, but 5 months. There was another article published in the New England Journal at the end of 2020 that looked at a bunch of patients who had cancer, and again documented persistent viral infection in patients much longer than the typical 10 or 14-day quarantine periods at that time. And I've shown an orange box over here for one of these patients that I'll zoom in on, and what you can see is up to day 60, right, 2 months later, there was persistent viral infection that was documented. And this is a genetic fingerprint, a schematic of a genetic fingerprint. And you can look that all the lines look to be just about the same, which strongly suggests that this persistent infection was the same virus and not the person being reinfected over and over again with a prevalent strain as well. So, and in fact, 2 of the patients in that particular study of patients with long-standing COVID had documented evidence of COVID like this more than 2 months after they were infected as well. Now, what about the severity of COVID-19? We know that it can last longer in patients who are immunocompromised. What about its severity? Well, there was a very nice study done by Ted Michaels and Brent England from Wichita, Kansas, out of the VA system. And they did a matched cohort study looking at almost 34,000 patients in the VA system who had rheumatoid arthritis and non-rheumatoid arthritis patients with, other diseases as well in the VA system. Their particular patient population was older, about roughly 68, so a higher risk for COVID, of course, for severe COVID. And their population was 85% male, which you would expect in a VA population. And they took a look at this population and found 1,503 COVID-19 diagnoses. And what they found was that rheumatoid arthritis patients not only had a higher hazard ratio for developing COVID-19, about a quarter higher, but they also had they also were a third more likely to be hospitalized or die from COVID-19. And that was the first signal that patients with RA, for whatever the underlying reasons, were at increased risk of severe COVID-19 infection. We're lucky that we have a remarkable resource available to us called the COVID-19 Global Rheumatology Alliance. So after the onset of COVID-19 in 2020, a bunch of rheumatologists based here in the United States and Europe, and headed by Janus Yazdani, who is our division chief here at San Francisco General Hospital and at UCSF, formed the Global Rheumatology Alliance, which was a doctor-reported registry to collect as much information as we possibly could in real time from patients who were diagnosed with COVID-19 who had an underlying rheumatic disease. And Janus helped build this very, very elegant and easy-to-use registry where doctors could report these cases. Now, of course, this isn't a randomized, double-blind prospective study. This is a registry, and it's subjective to all of the biases that could come into reporting cases, particularly with a bias towards more severe cases. So we do take some of this with a grain of salt. But that said, the registry has accumulated a remarkable amount of information that we can learn from. In total, this is now as of May of 2021. I'm using data that are now almost a year old, but not quite there. They'd already enrolled more than 15,000 patients in this registry, roughly evenly split between the United States and Europe. And what you can see is that the registry was relatively overrepresented in terms of patients greater than 65 years old, who of course we know from the press are at higher risk for severe COVID-19. In the US, about 16% of the population is over 65, and in this registry, about 22% of patients were over 65. Again, indicating probably that there is a somewhat of an underlying bias towards more severe cases that got reported in the registry, in particular patients who are older, because there's no skewing of rheumatic disease towards older patients. There are plenty of young patients who have autoimmune diseases, but the registry of COVID patients reflected older patients. In addition, there were many comorbidities that we know of that are associated with bad COVID-19 that were also well represented in the registry. Hypertension and obesity were a little underrepresented for various reasons I'll get into compared to the US population, while diabetes and lung diseases were overrepresented. Again, it makes sense for those of us who treat a lot of these diseases, but just take my word for it, that the registry overall was very well represented in terms of other medical comorbidities. And now we're starting to see a stream of studies that have emerged that have analyzed data from this registry to try to teach us something about what COVID-19 looks like in patients who have autoimmune and immunocompromised states. So one study published at the end of last year looked at 3,800 patients roughly from the registry, and examined the 390 deaths that occurred amongst this group, which is a roughly 10% mortality rate between March and July of 2020. Again, that's a high rate compared to what we traditionally seen in the general population, which is about 2%. And again, I think that more reflects the biases of who gets reported to the registry more so than it does, a five-fold increased risk of dying if you have an underlying autoimmune disease. I don't think that's the case. But I will say that the registry is still quite valid because that death rate decreased to 5% in May of 2021. And so while there is probably reporting bias, it does reflect our improved knowledge about how to treat this disease, how to prevent it, through vaccination and otherwise, that probably also resulted in a legitimate decrease in the death rate as well. Nonetheless, all biases aside, we can learn something from the information that's been published from the registry. First of all, we can see that the same risk factors that are associated with severe COVID-19 in the general population are also associated with an increased risk of dying if you have an underlying rheumatic disease. And that's age, being a man, smoking, in particular, if you're a rheumatoid arthritis patient and you smoke, and if you happen to have comorbid cardiovascular disease or lung disease. Having underlying lung disease or heart disease or cardiovascular type hypertensive disease and such puts you at increased risk for bad COVID-19. And you can see that on this very nicely on this graph where anywhere where the bars are to the right indicates an increased risk of dying. But what I also want to point out, and what's very important to all of us on this webinar, is that if you have moderate or high disease activity, no matter what your underlying disease is, whether you have rheumatoid arthritis, another connective tissue disease, or inflammatory joint disease, or whatever, you also are at increased risk for dying. So having uncontrolled underlying disease activity is also bad. In fact, it's probably just as bad as smoking, being a man, everything except perhaps really, really advanced age. So it really tells us something about what we need to do with ourselves and what doctors need to do for their patients before getting COVID-19. Now, which is basically control underlying disease activity. Now, in addition to having uncontrolled disease activity, some medicines were also associated with an increased risk of dying. Now, these are odds ratios compared to methotrexate, which is the underlying referent in all of this. So compared to methotrexate, the highest risk of dying were in patients who were treated with B-cell depleting therapies. And the most common one of that is rituximab. And you can see that here on the lower box. But being on any biological DMARD as a class alone also placed patients at increased risk for dying. Now, if we look at this more closely, and who gets severe COVID-19. No matter how you define severe COVID-19, this is another analysis of that same database by Jeffrey Sparks at Harvard, who looked at 2,800 patients. And no matter how he defined severity of COVID-19, whether you're hospitalized, on a ventilator or not on a ventilator, with oxygen or without oxygen, being on rituximab was not a great thing. In fact, if you were on rituximab, 22% of patients in the registry on rituximab were hospitalized on oxygen or on a ventilator. 22%, almost between 1 in 4 and 1 in 5 patients on rituximab therapy had severe COVID-19 by that definition. Also, patients on JAK inhibitors, and we'll talk about what a JAK inhibitor is in a second, about 1 in 6 of those patients also had what was defined as severe COVID-19 as well. So those were the two medicines out of all the immunosuppressives that stood out as being particularly bad. Now, again, as Dr. Sparks did his analysis, when he looked at patients, whether they died, whether they were on a ventilator, whether they were on oxygen, whether they were hospitalized in the first place, no matter how he defines severe COVID-19 in these 2,900 RA patients, when compared to anti-TNF drugs like Humira, Remicade, Infliximab, Cimzia, all those types of medicines, right? Those were the referent medicines. So compared to anti-TNF drugs, again, rituximab and this class of medicines called JAK inhibitors were the two medicines that were statistically highly associated with worse outcomes overall, no matter how he defined them, compared to being on an anti-TNF medicine. And again, this was not seen for other immunosuppressive medicines like what we call the IL-6 inhibitors like Actemra, or other types of medicines like abatacept, which are T-cell directed therapies. So again, Rituxan and JAK inhibitors appear to be associated with worse COVID-19 outcomes. Now, this begs the question, why is this? And so just a very brief cursory immunology lesson. Cytotoxic T cells, so this, we really have to understand something about the immune system and its response to viruses. So the way our immune system responds to viruses is we have cytotoxic T cells that can recognize when a cell is virally infected and can kill it. We also have helper T cells that when they see a virally infected cell can release proteins into the blood called cytokines that can activate other parts of the immune system to fight the virus. In particular, they can activate B cells. And virus-specific B cells that are, again, specific for the virus, and the plasma cells that they give birth to can produce antibodies that can neutralize, clear, or prevent viral infection of cells in the first place as well. So you need all arms of this cellular part of this immune system to actually be able to mount an effective immune response against viruses. So why is rituximab particularly associated with severe COVID-19? Well, rituximab is an antibody that binds to B cells. It leads to their death through a variety of different mechanisms. It causes the B cells to commit suicide. It also can lead to the immune system to destroy the B cells as well. And so it can effectively remove and deplete B cells from the bloodstream, but it doesn't deplete plasma cells. So B cells eventually give birth to plasma cells. They evolve, and some activated B cells evolve into plasma cells, and plasma cells make antibodies. So when you give someone Rituxan and you clear their B cells, there's no immediate effect on existing antibody levels. This such as the antibodies you may have had from previous infections or vaccinations or what have you. But there are profound effects on the ability to generate new antibodies to new infections and new vaccines, because you have to activate a new family of B cells that are specific for that virus or that vaccine, and have those B cells grow up to become plasma cells. And if there are no B cells left to do that, you'll have a neutered immune response. B cells do more than just make antibodies. They also can do other things in the immune system and activate various parts of it. So they're very, very important, more so than we probably ever realized, to the immune system's response against viruses like those that cause COVID-19. Also important to the immune response are something called interferons. They're called interferons because they interfere with viral replication. So when cells are infected with virus, they can sense this and they release interferons from themselves. And these interferons travel to neighboring cells and even back to themselves, the original cell, and they say, help, I'm infected. And they go around and they bind to specific interferon receptors on these other cells that activates a signaling cascade inside the cell that allows it to basically mount an antiviral response, to make them resistant, to help them interfere with the virus's ability to infect them and to replicate inside of them. So interferons are very, very important. And you can see here from this little schematic that interferons, when they bind to their receptors, activate something inside the cell called JAK. And there's a series of signaling steps and cascades that go on that lead to an antiviral response. But there are a bunch of medicines that we use to treat rheumatoid arthritis, psoriatic arthritis, inflammatory bowel disease, eczema, and atopic dermatitis, and on and on and on. These medicines are called JAK inhibitors or Janus kinase inhibitors. And some of the more common ones you may have heard of on TV are Xeljanz, which is advertised, it seems like nightly, every time I turn on the TV, Rinvoq, and Olumiant. These are a couple of these out there. And these JAK inhibitors block JAK over here. And by doing that, when interferons bind to their receptors, right, to initiate the antiviral response, they can't transmit their signals inside of the cells such that those cells can actually emit an antiviral response. And as a result, when this happens, it likely leads people to become more susceptible to viral infections. And for example, we've seen on the JAK inhibitors a higher incidence of shingles, for example, which is a reactivation of chickenpox, because there's no longer an effective interferon response to contain the chickenpox that somebody got, 50 years ago inside their cells, or inside their neurons, and the virus can basically become can recrudesce and become infectious again. Just so you know, and because this may be confusing out there, some of you may say, hey, wait a minute, Olumiant probably puts someone at risk for a more severe COVID-19 because it blocks interferon. But I also heard that Olumiant is actually authorized by the FDA emergently to treat COVID-19. And that's actually true. Patients who have severe COVID-19 and have wildly out of control inflammation actually could also benefit from the blocking of JAKs, because so many parts of our inflammatory system also use the same pathway of JAKs to basically create massive inflammation. So once people are already infected with COVID-19 and have severe COVID-19 inflammatory syndrome, in order to turn off the inflammation, one of the best ways we can do that is with a JAK inhibitor. But just keep in mind, that's a different situation than somebody who takes a JAK inhibitor routinely, who then comes down with COVID-19. They're still at risk for much more severe COVID-19 in the very beginning. Now, to highlight the importance of interferons in COVID-19, here are a couple of illustrative cases. This was first reported about a year and a half ago of two sibling pairs who developed particularly severe COVID-19, even though they were under the age of 35. They were all related, they were all men, and they were all found to have the same mutation in a gene that was shown to cripple interferon responses, in particular to viruses like COVID-19, showing that if you don't have working interferon, you get particularly bad COVID-19. That was followed by a very, very nice study that looked at almost 1,000 patients who had developed life-threatening COVID-19 and compared it to 600 plus patients who had relatively mild disease. And what they found were that the patients who had severe COVID-19, 10% of them had antibodies to interferons versus 0% of patients who had mild COVID. Again, implying that you have to have good functioning interferon to prevent yourself from having a severe form of COVID-19. And just to keep in mind, there are a lot of drugs out there that can interfere with interferon signaling, not just the JAK inhibitors, but there is now a new medicine just approved for lupus that some of you may have heard of who have lupus out there, called anifrolumab. That's an interferon receptor antagonist that's particularly good because interferons cause worsening disease in lupus as well. And so drugs that block interferons have efficacy, but they also potentially can increase the risk of getting a severe form of COVID-19. So take-home points. Risk factors associated with more severe COVID-19 in the general population are also relevant in immunocompromised patients. So we really urge our patients to lose weight if they can, to modify cardiovascular risk factors and such. But we also know that more severe underlying disease activity, regardless of what the disease is, lupus, RA, Sjogren's, whatever, is usually associated with more severe COVID-19. And so we really want to make sure that our patients have good, effective disease control, which may lead to long-term improvement in their overall chance of a good COVID-19 outcome. And finally, the type of immunosuppression one takes matters. B-cell depleting therapies like rituximab and these JAK inhibitors can impair the immune system in such a way as to put people at risk for more severe COVID-19. So these are some guidelines that have been published relatively recently from the American College of Rheumatology to tell us what to do if we are on these medicines and we get COVID-19. What should we do? Call your doctor, number one, and your doctor will refer to this, but I'll just give you the crib notes here. We hold antimalarials like Plaquenil, hydroxychloroquine, for example, because there are reports of cardiac arrhythmias in patients who have COVID-19 on these medicines. We hold immunosuppressants and biologicals in general while patients are sick. We do, however, not hold Actemra. That drug is actually authorized to treat severe COVID-19. And if you look at some of the data I showed earlier, there wasn't a lot of data to suggest that patients on that particular medicine have worse COVID-19 outcomes overall. And so that's one medicine that you probably can continue if you have COVID-19. Like I said, we probably hold all JAK inhibitors as well. And we hold them for about 7 to 14 days after symptoms have resolved in otherwise uncomplicated COVID-19. If someone's had severe COVID-19, been in the hospital for months, been on a ventilator, all bets are off. And I think that's a more individualized decision as to how long to hold and when to restart someone's medication for their disease. But for the rest of us who've had uncomplicated COVID-19, about 1 to 2 weeks is probably all we need to hold the medicine after we're feeling better. Now, how do we treat patients? So that's what we have to do with our medicines. How do we treat patients who are immunocompromised and get COVID-19? And this is something I really want to spend a few minutes on right now, because what's been causing me much angst over the last couple of months have been not only how many of my patients have gotten COVID, but how few of them have been aware that they are in the fast track line to be treated for COVID-19 in a way that other people are not. You guys out there who are immunocompromised are in a special category that allows you authorization to get some of these therapies, but you have to follow some very specific steps and be aware that you're eligible for these in order to receive them. Now, there's been remarkable progress in the development of antiviral agents that include Paxlovid, that you guys may have heard of, molnupiravir, and a medicine called sotrovimab that I'll talk about in a second. All of these up until now have had FDA authorization for use in patients who are specifically at high risk for progression to severe COVID-19. So they're not available to everybody out there in the general population. You have to be at risk for having a severe case of COVID-19, and being immunocompromised qualifies as one of those risks. But the indications to get this are actually kind of tricky. Now, the first medicine I'll talk about, sotrovimab, I actually gave to my mother-in-law and my father-in-law, both of whom are immunocompromised and at higher risk. And I am convinced that, at least in my father-in-law's case, it really turned around his illness very, very quickly. He was going in the wrong direction. Sotrovimab was, I'll say, authorized for the treatment of mild to moderate COVID-19 who have evidence of a positive PCR test. It was shown to have efficacy against Omicron, the BA.1 variant. However, its efficacy against BA.2 has come into question, and we'll talk about that. You could only use it within the first 10 days of symptoms, and you could not be sick. You couldn't be on supplemental oxygen or be hospitalized for severe COVID-19. So again, it's this Goldilocks scenario where you're at risk for severe disease, but you can't have severe disease already. So it's in that sweet spot. So you have to know you're infected. And even when you're not feeling bad, know that you probably should get treatments like this to prevent severe COVID-19. If you get sick, it's too late. And that's the problem. Now, alas, I use sotrovimab there as an example. Just a week and a half ago or 2 weeks ago, the FDA pulled the authorization on sotrovimab because there are laboratory suggestions that it may not work as well. There's no for BA.2. There's no clinical trial data for this, but the evidence was suggestive enough, and there's enough circulating BA.2 subvariant of Omicron in the general population that the FDA felt it wise enough to just pull the authorization for the antibody. However, there's a new antibody called bebtelovimab that we now have here in the hospital. I think we have a few doses of it here right now. It's similar to sotrovimab. The rules for administration are also similar within 10 days of being diagnosed within 10 days of the onset of symptoms and with a PCR confirmed diagnosis of COVID-19. And there's laboratory data to suggest it may retain efficacy against all of the Omicron subvariants, but the data are still being gathered by the FDA, and we'll have to wait and see where this goes in the coming weeks. Luckily, we do have oral antiviral agents that have come on the market in the last few months. The most heralded of these is Paxlovid. And in particular, it's heralded because its efficacy in reducing hospitalization or death in patients at risk for progression with COVID-19 was almost 90%. And you can see the actual numbers there went from 8% of patients progressed to severe COVID-19 in their trials to almost 0.7%. That was a 90% reduction. And in terms of deaths on the drug, nobody who got Paxlovid died compared to 7 who got placebo. Molnupiravir didn't have quite as impressive a reduction in hospitalizations, but in terms of deaths, it also reduced deaths down to 0 as well. The trick to using these agents, these are Paxlovid at least itself is a protease inhibitor, but the trick to using it is you have to use it within 5 days of the onset of symptoms. So it's an even shorter window, the Goldilocks window, than the antibodies, which I spoke about a second ago, like sotrovimab, which we can't even use anymore. But bebtelovimab, you can use up to 10 days. Paxlovid, you have 5 days. So this requires, if you feel like you're symptomatic, you got to go get tested, and you have to get tested and be diagnosed within 5 days of the onset of your sniffles, or within 5 days of the onset of your cough or your diarrhea or whatever it may be. Because if you wait more than 5 days, the pharmacies are not authorized to give this to you if they have it. And again, you may not be feeling particularly sick nor feel the urge to go even get tested, or if your antigen test at home is positive, or do whatever, but you should do it. And if you're immunocompromised, which I'll show you in a second, or you're at a higher age or at risk for severe COVID-19, you should take Paxlovid. But again, you can't be ill. If you've gotten ill already and you're in the hospital with your COVID, it's too late. Now, the supply still remains relatively limited and it can be difficult to locate. But again, I urge you to contact your doctor if you get COVID, and they will help you acquire this medicine. I've done it numerous times in the last several weeks. The trick to using Paxlovid is there are lots of drug-drug interactions. Now, who is considered at risk under the authorization? I have the list here. I won't read down the list, but you can refer back to this talk later on to see what they are. But if you have any of these other entities, including being immunocompromised, which you can see right here in the middle, right here, immunocompromised state, which I think most of you who are taking therapies for your autoimmune disease would qualify for, you are eligible to get Paxlovid, and you should absolutely push for that should you come down with COVID-19. Now, there are lots of drug-drug interactions. I won't go into all of these. That's a headache for your doctor and your pharmacist to deal with. And Lord knows I've had to work with this, but the pharmacies are getting better and better, and we have automated checkers to make sure that there aren't interactions. And if you're on a medicine that reacts, we would probably just ask you to stop it unless there's a real reason to be on it, like an anticoagulant or something. You would stop these for a short period of time while you're taking Paxlovid as well. But again, just to remind you, this is the ultimate supply chain headache. This is a selfie from our daily update here in the hospital from a couple of weeks ago. And you can see the number of treatment courses we have of these is relatively limited. We only have 6 treatment courses, for example, at least a couple of weeks ago. Bebtelovimab, for example, and Paxlovid, we had 100. So once the first 100 patients, we have more than 100 patients with COVID getting COVID every day. So you can see that the supply is relatively limited. And so you should advocate for yourselves if you come down with COVID to make sure you get one of these treatment courses with one of these medicines if you can. Now, I'll spend the next 5 minutes talking about vaccination for a second, and then I'll end by talking about other forms of prevention. How we vaccinate immunocompromised patients is a little bit different than how we vaccinate the general population. And the rationale for treating patients differently is as such. We know that there's unquestioned efficacy of vaccination to reduce the likelihood of severe COVID-19, both hospitalization and death. That's been well established. The studies are out there. The vaccines have been used now in billions of people. And we have lots of data to show their efficacy as well. It's really remarkable. But there are lingering questions about the efficacy of vaccination in immunocompromised patients. In particular, do immunocompromised patients have as good a quantity and quality of antibody responses because of those plasma and B cell things we talked about? Then we don't know about the magnitude and quality of the cellular immune response, those T cells we talked about. We don't know if that may be fine to talk about these things hypothetically in a lab, right? But is there actual reduced clinical efficacy of vaccinations in immunocompromised patients to prevent symptomatic and severe COVID-19? Maybe the antibody titers aren't as high, but if it doesn't have any clinical difference, if patients aren't getting any sicker, it doesn't really matter, right? So what are the clinical data that we have out there? And finally, what is the durability of vaccination? Are patients who are immunocompromised, does the durability of that protection last as long as it does for people in the general population who are not immunocompromised? So let's look at the literature here. We have some data on vaccine efficacy looking at transplant patients. This was a study looking at 400 transplant patients. In this study, the minority of patients had detectable antibodies to the vaccine after a single dose, only 17% of patients. Now, of course, we give 2 doses. And if you're immunocompromised, like I'll speak about in a second, we actually give 3 doses up front. But the reasons for that are based upon studies like this that showed such weak immunization to a single dose. And in fact, patients who are taking mycophenolate and azathioprine were 1/5 as likely to actually develop antibodies against SARS-CoV-2 compared to patients who were on other immunosuppressive therapies. We now have better data looking at kidney transplant patients. These are data published fairly recently. It looked at patients who received 2 doses of the mRNA COVID-19 vaccinations. And you can see compared to patients who were otherwise healthy controls, 100% of patients had seroconverted and had neutralizing antibodies to COVID. Whoops, sorry about that. But only 24% of patients who were kidney transplant patients on immunosuppressive medicines had neutralizing antibodies. Furthermore, those were antibodies to the alpha variant. If you looked specifically at patients who developed antibodies, not looking at the patients who were negative, but the patients who actually were positive, and you look in this group of patients here, there were 36 patients who actually had a good response and had neutralizing antibodies to the alpha variant. Only 2/3 of them had antibodies that were good enough to neutralize the Delta variant. And again, we don't even know about Omicron. So it looks like, as compared to 100% of patients who were not on immunosuppressive medicines. So it looks like kidney transplant patients on their immunosuppressive regimens have impaired antibody responses to COVID vaccination. And this led us here at UCSF, along with partners at Washington University, to do a very large study looking at the effect of immunosuppressive medicines on the immune stimulating abilities of these mRNA vaccines. And you can see over here, we looked at over 130 patients with a variety of different diseases. This includes gastrointestinal diseases, arthritic diseases, other autoimmune diseases, including lupus and such. So we had a very nice representation in our study. There was also a very nice representation of medicines and immunosuppressive therapies that patients were taking as well. And what we found were, the good news is that almost 90% of patients who were immunocompromised had antibodies to SARS-CoV-2 induced by vaccination. Now, that was lower than the 100% of controls who seroconverted, but it was still a relatively decent number to say. But it was still, like I said, about 10% lower or 12% lower than in the controls, all of whom seroconverted. Now, some of the patients within that group had much lower titers of antibodies than others in the immunocompromised group. And in particular, if we looked at who those people were, patients taking corticosteroids like prednisone, and you can see that over here, had lower levels of antibodies compared to immunocompromised patients who are not on prednisone as well. And the biggest difference were in patients, drum roll please, can you guess? The patients taking rituximab, our good old friend, the B-cell depleting therapy, and you would expect that, it makes sense. There are no B cells around in patients who are on rituximab to mount an immune response against the new vaccine and give rise to the plasma cells that will make antibodies that are protective, right? And you can see here that the antibody titers were almost zero in patients on any B-cell depleting therapy compared to immunocompromised patients who were not on a B-cell depleting therapy. And those patients were only a little bit less than patients who were in the control group as well. So being on rituximab was not a good thing. The good news that we saw is that it's not a permanent thing, right? Eventually rituximab wears off, the B cells can come back, and the longer it's been since your last rituximab infusion, the more likely you are to have a good antibody response to COVID vaccination. So what we've done with a lot of our patients on rituximab is, if we're able to do it, if their underlying disease, whether it's granulomatosis with polyangiitis, which is Wegener's, or if it's rheumatoid arthritis or whatever, is well controlled enough on the rituximab, we'll hold off the next treatment course as long as we can to ensure that we get the best possible vaccination response we can get before we'll give the next dose of rituximab as well. Now, that's the lab-based testing, looking at antibodies and things like that. What's the real-world efficacy of vaccination? We have a very nice study published at the end of last year from the Centers for Disease Control that looked at the efficacy of 2 doses of the mRNA vaccine to prevent COVID-19 associated hospitalization more than 14 days after they were fully vaccinated. And they looked at 20,000 immunocompromised adults, about 50% of whom were fully vaccinated. And they looked at 70,000 immunocompetent adults, about 40% of whom were fully vaccinated. And they define immune compromised as patients who had malignancies, whether they were solid or hematologic, whether they had underlying rheumatologic or inflammatory diseases, or other intrinsic immune conditions or immunodeficiencies, or were transplants. And what they found in the real world, how well did the vaccines work in the immunocompromised versus the immunocompetent patients? Patients who were immunocompromised, the vaccines were 77% effective at preventing hospitalization and severe COVID-19, compared to what we now know to be accurate data, about 90% protection in the immunocompetent population. Now, this varied depending upon how you define immunocompromised. The vaccines were about 60% effective in patients who were organ or stem cell transplant recipients, and about 80% effective if a patient, for example, had an arthritic or rheumatologic or inflammatory disorder as well. And these differences were the same no matter what someone's age were or what vaccine they were on as well. So again, we have laboratory evidence and we have now real world evidence that the vaccines absolutely protect us, whether we have compromised immune systems or not. It's just there's a little bit, there's a significant but relatively modest reduction in protection if you're immunocompromised. Now, that's what raised the question about whether or not we should be giving extra doses of the primary injection series or boosters to people who are immunocompromised. And this was a very nice study looking again at in the cancer world, and it showed that particularly if you have a leukemia or lymphoma, these patients were particularly poor responders to initial COVID vaccination. Less than 20%, for example, responded. But again, if they were given a boost at 21 days, that response rate went up to 60% in patients who were significantly immunocompromised. And so based upon studies like this, we know that antibody titers may be reduced in some patients who have autoimmune diseases who take certain therapies, particularly B-cell depleting therapies like rituximab, and possibly with other immunosuppressive medicines like prednisone, JAK inhibitors, and drugs like methotrexate and other antimetabolites. There's a suggestion that there's also a corresponding reduction in viral neutralization as well, but boosting does appear to augment the immune response to these vaccines. And so the Centers for Disease Control has modified their recommendations in the last several months to recognize this. And so if you're immunocompromised to begin with, and you're being vaccinated for the first time for COVID, you're eligible for 3 primary doses of the mRNA vaccine that should be given at 0, 3 weeks, and then what would be 7 weeks or 4 weeks after the second dose. So it's a series of 3 immunizations over the first roughly 2 months or so. And then you give the booster on top of that. The first booster is a 4th dose that should be given at least 3 months after that first primary series of 3 injections. And now, if you're over the age of 50 or you're immunocompromised, you're eligible for a second booster dose, which should be given at least 4 months after the first booster. So that may seem a little bit confusing. So if you're not immunosuppressed, you get the 2 primary shots to begin with, you get the 3rd booster at least 3 months later. And then if you're over the age of 50, you can get a second booster or a 4th shot. If you are immunocompromised, you should have gotten 3 doses up front, although many of us got immunized before these recommendations came out. So that didn't happen, but you get 3 doses up front. A 4th dose then becomes the booster dose, and a 5th dose becomes that second booster that the CDC authorized. Now, is there anything we can do with our medicines to improve the likelihood that our vaccines are going to work better? The answer is yes. We can probably hold our medicines if we're able to. Of course, if our diseases are out of control, we don't want to do that. But if our arthritis is under relatively reasonable control, we have data from the influenza literature that holding methotrexate for even just a couple of weeks can improve immunization to influenza by up to 25%, like you can see over here. I won't get into the specifics of the graph. And so based upon that, the American College of Rheumatology has come out with recommendations that basically tell us to do just that, to basically hold for 1 or 2 weeks our immunosuppressive medicine up to right at the time we're going to get our COVID dose, up to 2 weeks after we've gotten our COVID vaccine dose. And then we can go and resume our therapy as well. It's a little bit more complicated if we're taking other biologicals and things like that. And I've put the recommendations over here. There's a general lack of consensus for some of these things, but by and large, for the majority of medicines that all of us out there are taking for our arthritis, if you just hold 1 or 2 doses, say, of your weekly methotrexate, that's good enough, and it has a chance, at least if this were influenza, to boost your likelihood of responding to a vaccine by maybe 20 or 25%. And so that may potentially help as well. Now, in the last minute or two, I want to talk about the power to prevent. Obviously, vaccination is the key to reducing the morbidity and mortality associated with COVID-19 in an immunocompromised patient population. Now, we know that vaccine, as I just showed you, because these vaccine responses might be impaired to some degree in patients who are immunocompromised, we should also give, in addition to vaccination, we should give consideration to actually therapies that can prophylax immunocompromised patients from getting COVID-19, or at least severe COVID-19 in the first place. And this is called primary prevention. Is there anything we can do on top of vaccination? And the answer is yes. There is a medicine called Evusheld that's out there. It's actually a combination of 2 monoclonal antibodies that I can't pronounce, but it's a cocktail that recognizes 2 distinct regions of the spike protein on the SARS-CoV-2 virus. And it's been modified in a very clever way that gives it a very, very long half-life. So it stays around for a long time. And it's been shown to be effective at neutralizing the virus and protecting against infection. And it appears to have at least some partial, if not decent, ability to neutralize even the Omicron subvariants. So it's given as 2 separate intramuscular injections, one for each of these antibodies in the cocktail. And a single dose has a half-life, meaning half of it stays around for over 80 days. So it has the potential to provide a long duration of protection. And hot off the press today, I literally put this slide together 5 minutes before I came on this talk, is a study in the New England Journal of Medicine. We've been waiting for this to come out, of the PREVENT trial, P-R-O-V-E-N-T. It was a phase 3 pre-exposure prevention trial. It looked at unvaccinated patients who were at risk for severe COVID-19. Admittedly, this was before the Omicron variant came out. This was in a Delta predominant population, exposed population. But like I said, at least in the laboratory, it looks like this therapy retains some efficacy against Omicron. And what the study showed is that there was an over 80% reduction over the course of 6 months in the risk of getting symptomatic COVID-19 compared to patients who did not get placebo. Now, analysis is ongoing to determine how long this drug really can protect us. Is 6 months the limit? Maybe it can last for even longer. And it's particularly effective if for some reason you're not able to get the COVID vaccine. If you've had a reaction to the vaccine, or for whatever reason, you're an allergy, you're not able to get the vaccine, this is for you, because this can actually help prevent severe COVID-19, at least symptomatic COVID-19, by about 80% up to 6 months. And in fact, like I said, this antibody, although it was optimized against Delta and studied, I should say, against Delta, against Omicron, it's been shown to have about a 30 times decreased reduction in its ability to neutralize the Omicron subvariants rather than Delta. But the dose has since been modified by the FDA. It's been doubled, and it's felt that with this double dose, that 30-fold reduction in activity against Omicron compared to Delta is probably can be overcome by giving this higher dose. And so again, if you're a patient who's already received the initial dose, the original 150 milligram dose, what we say, and it's been within 3 months, we'll give you a second 150 milligram dose of each of those of that cocktail. If it's been more than 3 months, we'll just give you Evusheld again at the full 300 and 300 dose. But either way, we think giving this 300 dose of this medicine can help prevent infections, even in our patients who can't be vaccinated, or even if you are vaccinated but are at increased risk for having a less than protective response compared to the general population. So again, it's authorized by the FDA for pre-exposure prophylaxis. You therefore cannot be currently infected with COVID. You have to have no recent exposure to COVID in order to get this. And if you have moderate to severe immunocompromised states due to a medical condition or immunosuppressive medicines, or if you're at risk for COVID-19 and unable to get vaccinated, you are eligible under the FDA's authorization to get this. And we have this here, and I am giving this now actively to my patients, particularly those who are, even if they're vaccinated or have gotten that rituximab or have gotten those JAK inhibitors, I'm trying to get them this medicine, or if my patients have been unable to get vaccinated otherwise as well. And so with that, I thank you all for your attention for the past hour. I'm going to hang around for 5 or 10 more minutes and take as many questions as you may have. Again, we've been through this over the last 2+ years. It feels like we should be nearing the end right now. We're probably, like I said, close to the end of the beginning rather than the beginning of the end as this infection becomes more endemic in the population. But like I said, there's a lot of discoveries and progress that are being made every day, and myself and others, my colleagues who are your advocates as your arthritis doctors, are out there thinking about you and constantly working to come up with the best ways that we can help you deal with living in this brave new world that we live in. So thank you very much.
Thank you so much, Dr. Graf, for that super informative presentation. I hope that at least from what I've taken away, there's lots of good information to take back to everybody's own physicians and healthcare providers to help them make the most personalized decision that they can. So I've seen 3 questions in the chat. 2 of them are pretty similar. It's the theme is around second boosters or boosters in general. And so the first question is whether or not second vaccinations are recommended. And then the third is about suspending TNF blockers a week or 2 before getting a second booster.
Great questions. Those are excellent questions. So I deliberately skipped over. Let me answer the last question first about the TNF blocker. The data are, when the ACR tried to come up with guidelines, I believe that was one of, if you go back and look at that slide that I showed, there was debate. They couldn't reach a consensus. So do I make patients stop there? I have seen some patients get great responses, and I've seen some patients not get great responses when I measure their antibody levels. Mind you, the CDC does not recommend checking antibody titers routinely after you've been vaccinated, because there's no evidence to suggest that those antibody titers say anything about your likelihood that you're protected or not protected. Nonetheless, we have done these studies, and there is some reduction overall in patients on TNF inhibitors, but it's not severe per se. And so I think it's up to you. If your disease is well controlled, that's why, by the way, there's no consensus on this. If your disease is really, really well controlled and you can afford to skip a week, say you're on Humira and you take it every 2 weeks, you can afford to skip 1 dose, I would do it and get the vaccine, skip the next dose, and then go on after that. But if your disease is like, if you feel it coming on, if you even miss or are late with one of your doses, don't skip the dose. Just go ahead and get boosted when you should be boosted, and you're probably going to be okay. So it's not a hard recommendation that I'll give you to stop the TNF blocker. But if you're able to do it, sure. It can only help, right? So then we have a question. I have both the vaccines. Should I get a booster? The question of, so this is, I assume this is a person asking the question that they're immunocompromised or not immunocompromised. So if you're immunocompromised and you're getting vaccinated for the first time, you actually get 3 shots up front. So everybody thinks that 3rd shot is a booster. It's not. It's part of the primary vaccination series. And so if you're immunocompromised and you got your vaccination last year before we were doing that regularly, keep in mind with the fact that you actually were sub-vaccinated, right? The efficacy, you should have gotten 3, but we didn't know to give 3 back then, right? So your 3rd, you should absolutely get boosted because you got only 2 shots in the beginning instead of 3. If you got vaccinated later when we were giving 3 shots to an immunocompromised person, you should absolutely also get a 4th shot, which is your booster shot. So whether you got 2 shots or 3 shots as your primary immunization series, you should get the next booster. So the first booster, no matter how many you got up front. The second booster, which is another question we had here, is a little bit of a different question. So the data aren't really fully baked yet to let us know whether or not the second booster, I should say, the 4th shot for some or the 5th shot for others, really is necessary. There are data from Israel that suggest that there is efficacy to getting a 4th booster shot, particularly if you're older. The older you are, so the FDA's cutoff for the extra booster for all of us in the United States is an age of 50. Anyone over the age of 50 is eligible because age is really the determinant about how much efficacy there is in the booster. If you are not immunocompromised and you're under the age of 50, you can't get it, and you're not really allowed to get it anyway. If you're 50 to 60 or 70 years old, the amount of bang for your buck is probably not that great. It's not nothing. I mean, you do get some benefit, there's no question. And the risk of an adverse event to the 3rd or 4th time you get the shot is not that great either. So it's probably worth it to get the shot, but it's not like you have to sell the farm in order to get it. I wouldn't be, running down the street to get myself the 4th shot right now if I fall into that category. If I know that I'm going to go to a college campus, or I'm going to be traveling internationally, or I'm going to be being around airports or in a large indoor setting, yeah, I would get the 4th booster. I would get the extra, I should say the 2nd booster shot, certainly, if I'm able to get it. If I'm immunocompromised up front, I'm more likely to want to get the extra shot, even though the data aren't out there about how much more efficacy that second booster provides. But it makes sense that I probably would want to get it. And certainly if I'm over the age of 70, I think then the data from Israel do suggest that there's a further significant reduction in hospitalizations and severe COVID-19 with the second booster. And you know, all of our immunity wanes, whether we're immunocompromised or not. So the vaccines clearly have less efficacy the longer out we are from our last vaccine dose. So if it comes around, you know, if you're, 6 months from now and you're looking at going to, Poland or something and you want extra, I would get the extra booster shot. But it's not like you have to rush out now to get it, because if you're, 50 to 60, you're on modest immunosuppression, you're probably good with the first booster, but you absolutely should get the first booster shot.
Great. Looks like Diana has a couple of follow-ups there. Immunocompromised with one booster, a second one effective or might have a drawback. I'm not quite sure what that means, perhaps.
I think I know what she means. So let's see if I guess this properly. So yes, the Israeli studies, I believe, have looked at, there are other Israeli studies that have looked at immunocompromised people. I don't know if the second booster studies have looked at them. They have the advantage of having a nationwide healthcare system, and they also have the advantage of having a specific arrangement with Pfizer to provide the vaccine to them, and they have this data exchange going on constantly between the company and the country. It's resulted in a remarkable partnership to generate all these data. So I am sure they do have those data. Whether that's part of the published data, I don't know. Don't know them well enough specifically. But I will say that if you are immunocompromised with one booster, the second booster is efficacious. How efficacious it is, it certainly isn't it doesn't provide as much boost as the first boost does. It looks like the first booster gives you a really good shot, at least for 4 or 5 months, at least after the boost. And it looks like if you get boosted a second time, you don't climb the mountain that much higher. You may be able to get up to where you were before, but not that much higher. And it looks like the clinical efficacy really diverges when you look at older patient populations. So if you're really older or you're on an awful lot of immunocompromised medicines, then I would get the fourth shot. And I've recommended it to patients, but I'm not going, I was begging patients on my knees, trading my firstborn child to get patients the original vaccines and to be boosted, right? I'm not doing that for the second booster. I'm recommending it, but letting people know that it's not the end of the world if they don't do it. And then there's a great question here about Evusheld. If you were able to and qualify for Evusheld, would you recommend dosing that instead of another booster as an immunocompromised individual? That's a great question, because now there's risk, right? How do you balance all these things? The risk to getting another booster. So first of all, you can't get both at the same time, because if you think about it, if you give someone, right, a vaccine that makes the spike protein, and then you give someone an antibody to the spike protein, they're going to neuter each other, right? It'll be a war inside your body for efficacy. And so you have to wait a certain number of weeks after you've been vaccinated in order to get Evusheld in the first place. That's a technicality that we in the doctor world have to know about, that you don't really need to know about. But yes, if you want to, if you're immunocompromised, and significantly so, if you're on rituximab, certainly, and maybe a JAK inhibitor, or if you're really significantly immunocompromised on a lot of prednisone and such, I would get the booster, and then I would wait the requisite, 3-4 weeks or whatever, 2, 3, 4 weeks, and then get my Evusheld after that. I would do both. If you feel like, you didn't feel great after you got your booster, it didn't make you feel well, or you feel like, certainly I would get the third booster. I wouldn't use Evusheld as a replacement for a third booster if you're able to get the third booster. The fourth booster, which may be beneficial, may not be, more beneficial maybe if you're more immunocompromised, I probably would get and then get Evusheld. But if you had to choose between one or the other, getting Evusheld is not a bad substitute compared to the second booster. So I would probably get the second booster and then get the Evusheld. Or you could take Evusheld, or the other way around. You could get Evusheld now, and then when it wears off in 6 or 8 months or 10 months, we'll either be boosting again or getting annual, COVID vaccines like we get annual flu vaccines, which is really what the deal is, right? The issue, if you don't want to get the second booster right now, the extra dose, right? The only reason really not to do it, if you fear having a reaction, if you had bad reactions to previous vaccines, or, there is this movement to have an annual COVID vaccine that's kind of like, specifically dressed for the variants that are out there. And if you want to make sure your immune system is primed and ready to go next winter, you might want to wait for that instead of getting your booster today, right? But there's no indication from the government or anywhere else that that's in fact happening or what's going to happen. So I would take the bird in the hand and get my booster now if you're really immunocompromised, and then, get the Evusheld in a few weeks, and then you've got like double protection.
Okay, one last question from Marissa. Can you see that, Dr. Graf?
Yes. Oh, there we go. So, Marissa, you have a 15-year-old daughter with rheumatoid arthritis who's on methotrexate. You got the Pfizer 2 doses in September, no booster, as it was new at the time. Does she need to get the booster now that it's been 7 months? Also, she did flare and had stomach issues from the vaccine doses. Okay, that's a good question. First of all, I have to double check to know whether or not I'm not a pediatrician, whether or not the COVID vaccine booster is authorized. I believe it is if you're over 12 years old. Don't quote me on it. But assuming that it's actually authorized, I would do the booster. I think that's worth it to do it since she's on methotrexate. If she had a horrible reaction to the other ones, again, don't want to torture someone as well. She's probably reasonably protected from the first 2 shots, but I would fairly strongly recommend that she get the booster. She may also be someone eligible for Evusheld, although she's actually under the age of 18, so I take that back. But again, since if not able to do that, I probably would favor getting boosted. So yes, I think that's a good idea.
Wonderful. I think that's the end of the questions. Thank you so much, Dr. Graf, for sharing your knowledge and your time with us, and especially staying a little later than planned. I think we all took really great, information from this, and really appreciate your time being here with us today. And thank you to everybody who participated. Thank you for taking that step towards your own well-being and healthcare to join us to learn today. So there will be a follow-up email. We'll link the recording. We'll share some resources. Again, that'll come from me. It'll have my email address and phone number. Please reach out if you ever need anything. Also, again, this is part of a quarterly series throughout the year. So we do have 3 sessions left throughout the year. The topics will be on integrative medicine, and we'll also have a session on osteoarthritis in August. So be on the lookout for that information when it's scheduled and registration is open. So thank you again, everybody. Thank you so much, Dr. Graf, and hope everybody has a great night.
Good night.
Thanks.